Hello, I'm Roger McIntyre, Professor of Psychiatry and Pharmacology at the University of Toronto, and very pleased to have worked with almost 2.5 dozen of my colleagues around the world, 5 continents, in our recent publication in the American Journal of Psychiatry Online, synthesizing the evidence for ketamine and esketamine, and how do we implement this treatment in our patients. We've come to learn that treatment-resistant depression, at least resistance to monoamine-based antidepressants in psychiatry, is unfortunately quite common. Manualized-based psychotherapies such as cognitive behavioral therapy are certainly very effective, but are not as sufficiently demonstrated to be effective in people with treatment-resistant depression as monotherapy. We were of the view that there was a need globally to bring together the evidence, a state of the union of sorts, not just on the evidence and the pharmacology, but how do we implement this? What is the right setting? What is the right patient selection? What's the appropriate safety surveillance? A couple of takeaway messages. First, ketamine and esketamine proven effective in treatment-resistant depression with rapid and significant benefits apparent within 1 day. We also took away the message clear that in depression with suicidality, ketamine and esketamine appear to be effective at attenuating depressive symptoms. It still remains an unanswered question whether ketamine and esketamine can reduce suicidal behavior in completion, but certainly reducing some aspects of suicidality. We also know that there are tolerability and safety concerns that we need to watch for. These would include, but not be limited to, aspects of dissociation, vasomotor effects, gastrointestinal effects, maybe neurologic effects, but also, in fact, let's be vigilant for any perhaps concerns around abuse liability, diversion, or gateway activity. I would say that the first chapter of this book has only been written, many chapters more to go. We need to learn how we can prolong the efficacy of ketamine and esketamine, not just by giving more treatment, ketamine and esketamine, but other modalities that we can give people, pharmacologic, psychosocial, to prolong the effect. Major depression is the condition most studied, but what about other disorders like bipolar disorder, post-traumatic stress, maybe even drug and alcohol abuse, or comorbid populations need more study. Thirdly, long-term safety. We absolutely need long-term safety data for these treatments more than we have now. We look forward to having it. Also, maybe there's some derivatives of ketamine that might be as, if not more interesting. The metabolites of ketamine, maybe some of the combinations of metabolites, that would be an interesting area to explore. And also, what can ketamine tell us about other rapid onset treatments in psychiatry that are currently being explored? We certainly are entering a new era in psychiatry. It's a hopeful area for people who have been affected by treatment-resistant depression, that we might be able to offer not just symptom relief, but symptom relief rapidly. And now our task is how can we make it safer and make it more enduring and make it more acceptable for people all around the world.